Our vignette centers on a 45-year-old man with a known history of FHH. He's been asymptomatic until recently, when he started experiencing recurrent severe abdominal pain. His diagnostic workup, including a CT scan, reveals pancreatic calcifications. His lab findings are consistent with FHH, showing elevated serum calcium but normal kidney function. The question posed is, what's the most appropriate next step in the management of this patient? Our goal at Avg Med Student is to make the highest quality and most up-to-date content on USMLE as accessible and affordable as possible. We spend a ton of time and money researching and recruiting content writers while bringing it to you at no cost at all. If you could please subscribe, leave some thoughtful feedback, and share the content if it helped you in any way. We'd really appreciate it. Imagine a medical puzzle, one that baffled clinicians and researchers for decades. A condition hiding in plain sight, often mistaken for a more common disorder yet distinct in its nature. This is the story of Familial Hypocalciuric Hypercalcemia, FHH, a fascinating genetic anomaly that challenges our understanding of calcium homeostasis. First recognized as a unique clinical entity in the late 1970s, FHH opened a new chapter in endocrinology, revealing the complexities of calcium regulation in the human body. FHH is not just a disorder. It's a tale of misdiagnosis, of patients who walk the fine line between normalcy and pathology, and of the scientific journey to unravel the mysteries of the calcium-sensing receptor. As we delve into the nuances of FHH, from its genetic roots to its clinical presentation and management, we uncover a narrative that is as much about human genetics as it is about the evolution of medical thought. So, let's embark on this journey through the world of FHH, where genetics, biochemistry, and clinical medicine converge, revealing a disorder that, while often lurking silently, has much to teach us about the delicate balance of minerals within our body and the intricate dance of hormones that governs it. Now, moving into the more detailed aspects of FHH that we discussed earlier. Familial Hypocalciuric Hypercalcemia, FHH, is an intriguing hereditary disorder transmitted via an autosomal dominant pattern. Its etiology lies in inactivating mutations of the CASR gene, which encodes the calcium-sensing receptor, CASR, located on parathyroid and renal cells. These mutations impair the sensitivity of the parathyroid glands to circulating serum calcium levels. Consequently, even in the presence of normal or elevated serum calcium, the parathyroid glands perceive a state of hypocalcemia, leading to inappropriate secretion of parathyroid hormone, PTH. The pathophysiological implications of elevated PTH in FHH are multifaceted. There's an upregulation of osteoclastic bone resorption, leading to increased release of calcium from the bone matrix. Additionally, there's enhanced gastrointestinal absorption of calcium and augmented renal tubular reabsorption of calcium and magnesium. Concurrently, there's an increased renal excretion of phosphate. Clinically, FHH can range from being asymptomatic to presenting with mild nonspecific symptoms like headache, fatigue, abdominal pain, or constipation. A rare but significant complication is pancreatitis, likely secondary to ectopic calcifications in the pancreatic tissue. Diagnostic criteria for FHH hinge on genetic testing, specifically for mutations in the KSR gene. Supporting diagnostic evidence includes a 24-hour urinary calcium excretion under 100 milligrams, which is a hallmark of hypocalciuria. Laboratory findings typically show mild hypercalcemia, hypermagnesemia, and hypophosphatemia. Often, there's also a notable family history of hypercalcemia. In terms of management, FHH is generally a benign condition and typically does not necessitate aggressive treatment. However, in cases where recurrent pancreatitis is a complication, a subtotal parathyroidectomy may be indicated to mitigate the risk of pancreatic damage. The answer choices range from various treatments like oral bisphosphonates, cinacalcet, vitamin D supplementation, aggressive hydration, to a surgical option, subtotal parathyroidectomy. Now, the key point being tested here is your understanding of the management of FHH, especially when complications arise. FHH is typically benign, often requiring no intervention. However, the development of complications like pancreatitis, as seen in this patient, changes the management approach. The correct answer is E, subtotal parathyroidectomy. This surgical option is indicated due to the patient's recurrent pancreatitis, a serious complication of FHH. It aims to reduce PTH levels, thereby managing the hypercalcemia and preventing further pancreatic damage. Let's briefly discuss why the other options are not appropriate. A. Oral bisphosphonates. These are used in conditions like primary hyperparathyroidism or osteoporosis, but not in FHH, especially not for treating pancreatitis. B. Cinacalcet. This medication is effective in secondary hyperparathyroidism or parathyroid carcinoma, but has limited utility in FHH. C. Vitamin D supplementation. In the context of FHH with hypercalcemia, vitamin D supplementation could potentially worsen the hypercalcemia and is not indicated. D. Aggressive hydration. While this might be used in acute hypercalcemia crisis management, it's not a long-term solution, especially for FHH with pancreatitis. In summary, understanding the nuances of managing FHH, particularly when complications like pancreatitis occur, is crucial. The decision to opt for surgical intervention in this scenario highlights the importance of tailoring treatment to specific clinical situations. All right, folks, that's a wrap on familial hypocalciuric hypercalcemia. We've cut through the medical jargon and laid it out bare, from its sneaky genes to the tricks it plays on the body. It's gems like FHH that show us there's always more weird stuff to learn in medicine, no matter how much of a know-it-all you think you are. If this info lit a bulb in your brain, go ahead and spread the word. Share this with your med school buddies. Let's face it, they could use a leg up. And don't forget to hit subscribe.